All righty. Well, thanks, Chris. And I think it's time to get started with the official program. So our first session will be Soften Up, Managing Post-Radiation Fibrosis and Trismus. It will be moderated by Dr. Ricky Sevjani, Assistant Professor in Residence of the Department of Radiation Oncology here at UCLA. Please join me in welcoming Dr. Sevjani. Thank you.
Good morning, everyone. My name is Ricky Sevjani. It's a real honor and pleasure to be here to help moderate this session. I'm a radiation oncologist here at UCLA. And first I want to thank, I haven't gotten to see her yet, but I want to thank Dr. May St. John, who recommended me to participate in this and has been an advocate and mentor for me and thousands of others. And although she's left us just a month ago, we miss her dearly already. But today's session, we're going to be talking about post-radiation fibrosis and trismus. And this is something that we cause even when, as radiation oncologists, even after we've cured the disease. So yesterday I was just with a patient who had metastatic HPV-positive squamous cell carcinoma. We radiated his spine. We did a novel clinical trial where we radiated him in 5 fractions to high doses. And we did circulating tumor DNA. And his PET scan is clean, his circulating tumor DNA is clean, and I saw him to scope him yesterday, and he's not able to open his mouth. And when I did get the scope in, his tongue is completely white from radiation just 3 months out. And so even that is a huge issue for him. So I have a whole panel here together who's been able to help us. And these conditions have a major impact on your life, your ability to speak, your eat, stay comfortable and active. So you're going to hear from speech and language pathology, physical therapy, as well as the survivor. And together they're going to highlight strategies for prevention. I'm probably going to learn some things as well because we send patients there, but we are not there with patients to see what they undergo. Early interventions, long-term managements, and other guidance and support for both patients and caregivers. So we'll get questions from people first in person, and then there's a remote Zoom audience, and at the end of the presentations, and there's going to be a tablet where I'll be able to see the questions coming in on Zoom, and we can do that as well. And you can introduce yourself in the chat on Zoom, so I can introduce you to the team and the questions. But first, let's start with a feedback and a poll question. So the question is, what's the biggest challenge when it comes to post-radiation fibrosis and trismus? So this is the Poll Everywhere link. If you hadn't pulled it up, you can pull it up now. And if you might not be seeing this, it's a lack of early education about risks, limited access to specialists or therapy, daily exercises are hard to maintain, pain and quality of life impact, or unsure, you just need more information. Great. So the results aren't on my screen, but it looks like pain is a big portion of this and the quality of life impact. So as well as the other topics, including limited access. So here we have the access to the therapist, so maybe we can find better ways to get you to them. So let's begin. I'd like to introduce first each panel member. First up is Mr. Wade Chernick. He's a 4-year survivor of throat cancer. He underwent surgery, radiation, and chemotherapy, so trimodal therapy. He now manages a range of post-treatment effects, including dry mouth, neck stiffness, and the need to avoid dry foods. And although the regimens were intensive, Wade considered himself to be fortunate. His side effects remain manageable, allowing him to continue practicing law and advocating for special education for non-English speaking clients. So Wade will speak with us shortly, and we have Heather Thompson. She's a speech and language pathologist at Cedars. at Cedars-Sinai, and Heather has been at Cedars for 7 years, specializing in support in head and neck cancer patients throughout their cancer journey, before, during, and after surgery, radiation, and other treatments. Her focus is on helping patients maintain the ability to eat, drink, and communicate with their loved ones during treatment and recovery. She also works with laryngectomy patients, helping restore their voice and their ability to eat and drink, ensuring the high quality of life remains central to their care. And finally, I'd like to introduce Terma Tufanian. She's a physical therapist here at UCLA Health Rehabilitation, where she specializes in working with patients recovering from head and neck cancer. She assists in patients in regaining strength, mobility, and overall function during and after treatment. Her care often includes helping people manage their physical side effects of surgery, radiation, and chemo, such as head and neck shoulder stiffness, swallowing challenges, fatigue, and lymphedema. Dr. Tufanian is passionate about restoring patients' independence and quality of life, tailoring exercise and rehabilitation programs to meet each person's unique needs. Following each person's talk, we will do the 20 to 30-minute Q&A session. So without further ado, I'm going to introduce and allow Mr. Wade Chernick to come up and talk to us.
Good morning, everyone, and thank you for being here. Thank you for allowing me to speak. I'm an attorney, and speaking briefly and attorney usually are not said in the same sentence, but I'm going to try. I'm going to try today. And my journey goes back to June of 2021. I was having trouble swallowing for several months. I had seen ENT specialists. They'd look in my throat. They couldn't find anything. I thought ultimately maybe the problem had to do with my digestion, so I had a colonoscopy done. And when I awakened after the procedure, the doctor looked at me essentially with disgust and said, "You have, if even that, a condition called globus, which is, yeah, maybe you have a lump in your throat." But the doctor then went on to say, perhaps you should consider taking medication to deal with anxiety and depression. And I struggled for about another month or two. The pain was getting worse. It was more and more difficult to swallow. And I knew that regardless of whatever my mental state might have been, there was something else going on. And ultimately, I had a regularly scheduled appointment with my internist. And I explained to him what I had been experiencing, and my internist said, "Well, let me have a look at your throat." He took a look at my throat and then said, I'm going to send you to see an ENT. And I said, "Great, when should I see the ENT?" And he said, "Now." Well, that raised a few suspicions, but I was happy. At least somebody, I felt vindicated. Somebody was listening to me finally. And so I had a short walk to see the ENT. Ironically, it was the same group that had found nothing in my throat, so that didn't inspire a lot of confidence. But at the same time, when I entered the office, I saw the doctor waiting for me. Now, I don't know about anyone else here, and with all due respect to our medical practitioners, how many times have doctors waited for you, right? So I knew something was up, but I still didn't suspect the C word. Well, the doctor took a look at my throat, and within about 15, 20 seconds, as I recall, says to me, "You have throat cancer." I said a word that I'm not going to mention this morning. I was in a state of shock. I thought I had something like strep throat. I said to the doctor, "Well, what are the chances that what I have is something that might present itself as throat cancer, but in actuality is a benign condition?" Well, the doctor said to me, "That's a great question, and the answer to your question is maybe less than 0.5% chance of that." And that word entered my mind again for a second time. And I was now in panic mode. This was not something that I was expecting, and I literally was hit over the head. I had a very long-standing friendship with a medical practitioner here in Los Angeles at the Hausier Institute, Dr. Brackman. I called Dr. Brackman. I said, Dr. Brackman, I've been diagnosed with throat cancer. Is there someone that you can recommend that I see? And he said, absolutely. You must see Dr. Uttam Sinha over at USC. He will help you. And he would be the person that I would see if I were in your condition. And so I visited Dr. Sinha, and I finally got answers. He reviewed the PET scans and the CAT scans and so forth, and he said to me, you know, the reason why this was not diagnosed all along is that your cancer was hidden behind your right tonsil. Nobody could have seen it. And so finally I'm getting answers. I had stage 3 cancer. That scared the daylights out of me. But Dr. Sinha was very calming. I needed somebody calm because calm is not my middle name. I was still in panic mode. My family can attest to that. And Dr. Sinha said, the way we can eradicate this is I believe that there is a significant percentage of your cancer that is outside membranes, and we can eradicate it through an 11-hour surgery, robotic. And at that point, you'll rest a month, and then you're going to need 6 weeks of radiation. Well, I did my due diligence because at the ENT doctors, he had recommended that I see another doctor and that specialized in radiation treatment. And I went to see this doctor, and I told this doctor that I had seen Dr. Sinha and what Dr. Sinha's recommendations were. And this doctor said to me, if you were my own brother, I would tell you, do not take the surgical route under any circumstances. It is an unnecessary risk. You can be treated strictly with the radiation. Now, what complicated matters further for me was that this doctor had, interestingly enough, also treated my mother successfully for breast cancer. So I had 2 very bright doctors with diametrically opposed viewpoints, and I'm fighting for my life, and I don't know what to do. I'm gravitating back and forth. On the one hand, I don't want to do the surgery because I'm afraid of the risk, but on the other hand, post-surgery, I will have lower doses of radiation, and I'll be zapped with high doses of radiation if I don't do the surgery. And so as a patient, I'm in a bind. I'm not a doctor. I don't have medical expertise, and I have to make the decision of my life. I went with Dr. Sinha. Thank God. Dr. Sinha saved my life. We did an 11-hour surgery. And after the surgery, Dr. Sinha came into my room at the hospital. And with cancer, there's always surprises. There's good ones and other ones. So he said to me, and this was a great surprise, he said, you know what, Wade? I got out most of your cancer. It was not in a membrane. It was outside, and it was a lot more than I even thought that I could extricate. And I was ecstatic. This was fantastic news. But there was a proviso, and that was, he said, you know, we did see that some of the cancer went into your lymph nodes. Therefore, the team is now going to recommend, in addition to radiation, that you also undergo chemotherapy. Whew. Well, I was all in, though. At this point, I decided I was going to do whatever it took, and if it meant I had to do chemotherapy, then that's what we were going to have to do. My third surprise came about 2 or 3 days later. Initially occurred at home. I was in a heated discussion with my wife. All right, an argument. She was right, I was wrong. Doesn't matter. And in the midst of that, all of a sudden, blood started rushing out of my mouth, like I've never seen in my life. Well, the good news is it stopped the argument right then and there. On the other hand, we knew that we had to get ourselves to a hospital. And we live in the San Fernando Valley portion of Los Angeles. We went to our nearest hospital. I'm holding on to a towel as copious amounts of blood is trying to escape my mouth. We run into the ER of the unit of the hospital, and they tell us there's nothing that we can do. And so on a Friday afternoon, my wife is braving LA rush hour traffic to get us to USC to treat this condition. Rush hour traffic on a Friday afternoon in Los Angeles is no easy endeavor. And I remember saying to my wife, tell the kids that I love them. And my wife said to me, be quiet, I have to focus on driving. And then she said, you know, you've got to stay calm. I will get you there. I will get you there, but you need to stay positive, and we'll get through this together. And she was right. We got to USC. They had found that there was a valve that maybe was leaking a bit, or a suture, I think, that had gotten loose, and they repaired the damage. So there are surprises that will always come up, but fortunately they all were resolved. So I now am in, I guess this is around July, thereabouts, June, July of 2021. I have about a 1-month hiatus before I start chemotherapy. And I did my due diligence, and I'm very happy to say one of the perhaps most pronounced measures of assisting me to get through cancer was that I found a swallowing expert through the team at USC, Dr. Brenda Villegas, who I believe will be speaking later today. And the first words that were said to me by Dr. Villegas were, swallowing is surviving. After the surgery, I had to learn how to swallow all over again. It no longer came naturally for me. Insurance only covered a small portion of it. I was out a significant amount of money, and believe me, it was the best money I ever spent. And I think that it really ameliorated things ultimately for me, having a swallowing expert by my side. So with the chemoradiation, all right, it was 6 weeks of hell. There's no two ways about it. But I attribute a few factors to helping me get through it. Number one, I had support. This is not a journey that one can undertake alone. I had my wife, my kids, my mother, my best friend Mark, and great medical support. And I also found an angel, Jim Franchino, a cancer survivor himself, who was there to guide me through this route. And I'm also volunteering as a coach in case anyone needs one in today's world where we have excellent communication nationwide. I'm here to help anyone that might be going through their own difficulties. It really helped having somebody who had walked the same walk that I was undergoing with cancer. The other part that I think really helped me in this journey was that I had something to live for. And for me, it was my family. We had our stuff like other families, or maybe even more, but the bottom line was I really wanted to live. I really wanted to live for my families. I wanted to make things good. I wanted so much to enjoy years with them. I couldn't imagine not being with my families. So whatever it is, it could be work, it could be family, a project. I think having something to live for psychologically really helped me through this process. Now, I have to say that I was really fortunate. All in all, I did not have a feeding tube, which was my greatest fear. I kept my taste throughout chemoradiation. I never had a metallic taste. I was able to eat regular meals. I did not lose weight. I did not have any kind of a tube in my throat. I really escaped the worst of this. I attribute it to excellent support, familial. I attribute it to excellent medical support. I attribute it to hard work. And whether we call it divine providence or blind luck, all of that played a treatment. So it's now 4 years later, and finally I'm getting to the point. I guess I wasn't able to be brief, but I'm doing my best. So regarding the fibrosis, yes, I still have difficulties with swallowing, especially dry foods. I do have dry mouth, that's 24/7. The radiation, the gift that keeps on giving, as they say. But it's survivable. I would say that, yes, I avoid dry foods because I know that I can choke on those, so I don't eat a lot of breads, for example. And as far as drinking, I have to do the hard swallows that I was taught, or water will come out of my nose. I believe that the scarring has played a role in that. As far as the lock jaw, the worst part of it for me has been every couple of months I will bite my tongue. I think post-surgery my tongue was moved a bit, and maybe there's a bit of an indentation. And because my jaw is maybe not as open as it used to be, I will have a tendency to bite my tongue occasionally. But that's really the worst of it. And I do a lot of exercises. I will, for example, I could be at a stoplight and I'm opening my mouth as wide as I can. I'm doing tongue exercises. Now, sometimes it gets a little weird. I'll look over at a car next to me and they're shooting me looks like, what are you doing? I want to say to them, I'm a head and neck cancer survivor, but they've drawn off with a look of utter contempt and disgust, and I don't care. I still do it because it is part of my survival. And as part of my survival, I have to say that from a psychological standpoint, I am far better off today than I was 4 years ago. I am living the life. I am 65 years old. I am working full-time. I am traveling with my wife, and sometimes with my wife and kids as well, all over the world, and I am loving life. And so if there's one lesson that I would like to impart, at least on my end, it's that a diagnosis of throat cancer is not the death sentence that I thought it was when it was pronounced to me. There is lots of good life ahead to be living. Just get good medical care, try to stay positive, and I believe that in the end things will work out. Thank you very much for listening.
Good morning, everybody. Can everybody hear me okay? First of all, thank you for being here. And before I begin, I'd like to extend a sincere thank you to the Head and Neck Cancer Alliance for the kind invitation to speak today. It's an honor to be a part of a meeting and an organization that is so important and contributes so much to the head and neck cancer community, not only for patients and caregivers, but also for medical providers such as myself. Like with that great talk from Wade, I learned so much that I feel like I can give to my patients. Like, you're not the only one doing exercises in the car on the 405. You can do this. I heard a guy do it, because when you hear these stories and they know another patient who's been through it, it has more weight. So thank you so much. So today I am going to talk about a condition that may not be widely known, but can have a significant impact on everyday activities. Not just speaking and eating, but even breathing. The coordination, this condition is called trismus, or a lot of people know it as lockjaw. So let's go back just a little bit. So what exactly is trismus? So this is the formal definition, but trismus is a condition where a person has restricted ability to open their mouth. So specifically 35 millimeters or like a 3-finger distance. So what causes this? It's typically due to spasm, fibrosis, or dysfunction of the masseter muscles. And it may, once again, seem like a small issue, but it can have profound effects. So what causes trismus? One of the most common reasons of head and neck cancer patients to develop trismus or limited jaw opening is due to treatment itself, particularly radiation therapy and surgery. Radiation, especially when it's aimed in areas of the jaw, face, and neck, can cause the muscles involved in chewing and opening the mouth to become stiff, inflamed, or scarred. Over time, this leads to tightness and reduced mobility, and sometimes gradually or even months after treatment. So I'm going to say that again. Even months after treatment, because I think that's hard to wrap your head around as a patient, because you want to be done and the recovery and those changes are still happening. Surgery in the same region can also contribute if it involves jaw joint muscles, mastication, or nearby nerves. Scar tissue can form in this area, limiting how far the jaw is able to open. And sometimes it's not just treatment. Tumors located near the jaw or in the muscles of the face can press on the nerve and invade these structures further. So while trismus can be frustrating, it's known and understandable side effect, and with early awareness and daily care, it can be prevented or managed effectively. How does trismus present? Restricted mouth opening is probably the most common, not able to open the mouth as far. Pain, tightness in the jaw, difficulty chewing or speaking, headaches, earaches, and in some cases, asymmetry of the jaw. The jaw kind of moves over a little bit, and facial swelling. It can develop suddenly, especially in cases of trauma or surgery, or infection, or gradually over time. So why does trismus matter? Why does it matter to me? Because it can make it difficult, painful for you to eat or chew, or even speak. It can lead to weight loss or nutrition deficits, increases the risk of aspiration and other oral infections. It can make dental care, brushing your teeth, going to the dentist, intubation, and other medical procedures extremely difficult. So understanding the causes and the management of trismus is critical, not just for patients, but for healthcare professionals across fields from dentistry, oncology, surgery, and even rehabilitation. So let's take a quick moment to highlight trismus in the head and neck cancer patient population. So I saw this number and I thought it was really interesting. Up to 40% of patients receiving radiation therapy to the jaw region can develop trismus. So that's a lot. It's a big number. Even with good prevention, some patients will continue to develop trismus after radiation therapy. But the good news is there are ways to manage and to improve jaw range of motion over time. The key is staying consistent with daily jaw exercises. Many patients benefit from tools like a TheraBite, stacked tongue depressors, jaw mobilizers, and applying gentle stretching, warm compresses. And you'll hear more about that from our next speaker, Terry, and to reduce the stiffness and boost circulation. And remember, you don't have to do this alone. You're not in this bubble by yourself. Stay in touch with your care team, your speech-language pathologist, your physical therapist, your dental specialist, your surgeon, your radiation oncologist. They can offer expert support and help to monitor your progress. And because this is also a caregiver event, I feel I might have made this up, but I feel like it is so true. Behind every great smile is a caregiver who said, "Did you do your jaw exercises today?" I love my patients who have great caregiver support because I don't always have to be the bad guy then. So I'd like to thank you all. As a caregiver, your role is incredibly important, and I think it's important to know that. You encourage daily routines. You guys are the ones watching for the signs of worsening, like increased pain, stiffness, avoiding meals and conversation, especially during radiation and chemotherapy when they're just trying to survive. You guys are the workers, so I thank you. With patience, persistence, and the right support, many patients don't see, or many patients do see these real improvements even after treatment. So your encouragement really does matter. And I know myself and the other medical providers in the room, thank you. So in wrapping up, just some key points to take away. Trismus is common, but it's manageable. It's manageable. Early and consistent action equals better outcomes, and caregivers are very essential to success. So, thank you.
Hi, well, I am just so happy to be here today and honored, and I hope that you're able to learn a little nugget of information today that you can take with you from my little talk. We know that radiation fibrosis is changes in the tissue that leads to kind of scarring and thickening, and it can lead to some stiffness and discomfort. And so what do we do about it? There are a couple different treatments that physical therapy, speech therapy can offer, which include manual therapy, exercises, devices, and compression. And I will just start by saying, before we get into any of that, I always like to educate my patients on the importance of skincare and the regular use of moisturizers and sunscreen. It's important to maintain skin integrity so that the skin can function optimally. And it prevents dryness, which can also subsequently prevent further damage and infection. And it promotes wound healing, especially in the thick of radiation. The other thing that I like to tell my patients are that the results are only as good as the compliance and consistency. Now, I can appreciate with everything going on, all the oral care, dental care, swallow exercises, it's a lot. But as Wade demonstrated, there are ways to throw it into your day and make it convenient, right? You could just do it in the car and add it to your routine and kind of have it flow. So I'm going to just jump into manual therapy. Some techniques we have are massage, scar mobilization, and lymphatic massage. Now, I will say also that one of the side effects of cancer treatments can potentially be lymphedema, which, if left untreated, can also develop into a type of fibrosis. So if that's an issue, we can also educate you on lymphatic massage. So I just will do like a quick little demo on two of the easy ones for trismus, some manual therapy massage that you can do, that you can really do anywhere. So for the lateral, oh, thank you. Thank you. Ah, that's so much better. Thank you. So for the lateral pterygoid, it's a muscle right in here. And so what you're going to do is you can take your index finger, pad side, and go into your cheek, between the teeth and the cheek, and you're just going to press. Can you guys hear me? Is that okay? And it often is very sensitive and tender, so go gently and easy, but as most patients say, it hurts so good, and you often feel a release right away, oftentimes. Masseter is also a really easy to access muscle. It's between the space, I think of it as like between the ear, the cheek, and the jaw, so right around here, and you can just add pressure. And for each of these, you can do about 10 to 15 seconds, and you should hopefully feel a little bit of relief and things opening up. Scar mobilization, you can just take any cream or lotion and rub on the scar. We're just trying to break up those adhesions and free up the tissue a little bit. You can also do techniques like pinching it and rolling it, but that's once it's healed enough. And I'll just move on to exercises. So to help continue the range of motion and freeing up of the tissue, stretches are really important. If you guys are interested in the specific stretches, we can talk about that in the Q&A, but some of the most common muscles are to kind of target are the scalene, the sternocleidomastoid, and the upper trapezius. And then there is a nice range of motion for the neck with the towel. It's just passively. You can just help rotate the neck. For the jaw, for trismus, you can often do, it's important to maintain range of motion with lateral deviation, left to right, as well as protrusion, going to the front. And also opening, which is a nice segue into devices. And so if you guys have seen these, the Aura Stretch and the Therabite, I personally like them both. I don't have a preference. I think they are both easy to use and just as effective. It works for the Aura Stretch, you squeeze that backside, and you insert the mouthpiece into the mouth, and as you squeeze, it helps open and give you a stretch to open further. For the Therabite, you squeeze more towards the front, and it helps open the mouthpiece. And I defer to your provider to direct you on proper use, but some of the parameters and protocols we use are the 5-5-30 and the 7-7-7, which the 5-5-30, 5 times a day, you do 5 repetitions of a 30-second stretch. Or for the Therabite, you can do for the 7-7-7, you do 7 times a day, 7 repetitions of a 7-second stretch or opening. And then there is also compression garments, which look like torture devices, but they're actually really soft, and the foam in it is really cushy. And the way that these work is they're fit to be a little bit snug, and as you move, and just even as you're breathing and kind of twitching, it creates like a micro massage effect, which also helps break up fibrosis and reduce lymphedema if you have any. And as Wade showed in his picture, there's also compression pumps, which is a nifty little device. It has these little chambers which inflate and deflate in the order of kind of the lymphatic massage, which is also really nice if you have lymphedema. And that is it. Tried to keep it brief. Any questions? We'll move on.
Thank you, everyone. Let's give one more round of applause for Wade, Heather, and Terry for sharing their expertise. So now we have a little over 20 minutes for some questions, both from the virtual audience and the in-person audience. The virtual audience, I'm told that there's a chat stream on the right side of your screen. If you want to ask a specific question to a specific panel member, please go ahead and put it in the Q&A and submit your question, and we'll do our best to answer all of them. I think I have the tablet that will see your questions, so I'll try to follow along. And then for our in-person audience, there's Dr. Lauren Evans from UCLA and Dr. Bev Garber from UC Davis. They'll be circulating with a microphone. So if you want to raise your hand, we'll start with you, and I will try to come and answer any questions that you have to any of the panelists. While people might be thinking about questions, maybe I'll get things started by asking one that some of my patients have asked me, is that if you're dealing with trismus, fibrosis, these things, who should they see first, or in which order, or should they be seeing both Heather and Terry, the speech and language pathologist, or the physical therapist? And is there any overlap of the services? And which person might be best for someone to see for which indications?
Is it on? Okay, great. I think it varies probably from facility to facility. I would say the first person to start with would be your doctor, your surgeon, your radiation oncologist. At our facility, during chemo and radiation, they see me, because what we're trying to do is, and I'm a speech pathologist, is to eliminate an extra appointment for the patients. So I kind of take over the stretching, the jaw range of motion. I take that all on to get people through chemo and radiation. Then after you finish, we kind of then flip to the physical therapist, because I think Wade kind of said it with the speech pathologist. We want to keep you swallowing, but we also want to keep things moving during radiation and chemo. So to save an appointment, that's how we do it at our facility. So first your doctor to get the referral, then the referral. At my facility, if you're in chemo radiation, you go to speech. If you're not, you'll go to physical therapy. And I'll just be realistic too. Sometimes it's, if speech can get you in sooner, you start with speech, and if physical therapy can get you sooner. So I have to have a close collaboration with my physical therapy colleagues, because if they're like, we can't get somebody in for a month, and I have a 2-week wait, they're gonna come to me first. So sometimes it's just logistics.
Yeah, I agree with that. I think yeah, basically ditto.
That's great. That's really helpful for us too. I think there's a question here.
Hi there. Is that on? Yes.
Yep.
I'm a survivor of HPV-related tonsil cancer, and I just had a few comments and then questions as well. I went through treatment 11 years ago, radiation, chemo, radical tonsillectomy, neck dissection. The Aura Stretch and the Therabyte, are those things that I could use now, 11 years later, or are those things for people right out of treatment?
No, I think it's never too late to work on it and improve it. You can definitely, if you haven't done it before, you can definitely start even now if you're struggling with limited jaw range of motion.
I go to the dentist 4 times a year, like for cleanings, and it never feels good to have my mouth open, and so that was a question. And then that Therabyte or Aura Stretch, are those recommended by the dentist or the head and neck surgeon, or where do you hear about that? Which practitioner?
I think it depends. I think some insurances cover it if you can get a prescription from the physician. I don't know if we as physical therapists can do it, or I think it's available to purchase on your own as well. Okay. But I can definitely talk to you more specifically about that. But yeah, I would say your surgeon, your doctor would be the first person to speak to.
And then my last comment is that, because whenever I'm in a group like this, I always learn from everybody, no matter how long I've been out of treatment. But I have been getting a whipping, like popping, not good feeling, starts at the top of my head and goes down to the right side of my neck. And my chiropractor / massage therapist, like 2 people I see often, said that it could be for my scalene, and the nerves. And so if anyone else is going through that, for me, I go to yoga 4 to 5 days a week and get massages and see a chiropractor, and it has stopped 90% of the pain.
Good.
So that's just if anyone in the room is dealing with any of that. So thank you. And
I'm so glad
appreciate
to
you
hear.
sharing your story.
I'll just make a comment to Jason about the OraStretch and Therabite. I think online you can find it. I think it's Cranio Rehab is the company, and either is an out-of-pocket expense, but sometimes insurance might cover it, so you can certainly do some research on that.
Great, over here.
Hi, everyone. I'm Tessa. I'm a speech pathologist from Boston, and a lot of my patients that I have worked with can't afford the Therabite or the OraStretch because it's over $400 or $500 and it's not covered by insurance. So people ask, so if I can't use the Therabite, then what else can I do? So the most obvious thing that most people think about are tongue depressors. And my experience is that you can add tongue depressors that you can put centrally between your teeth, but you can also put them side to side. And I think that if you have one side working better than another side, putting your tongue depressors side to side and adding, so you put the tongue depressors in, and then when you get to the maximum, when you know you can just go like 1 millimeter more, you put the tongue depressor between the ones that are already in your mouth. If you understand what I'm saying. And that can be very helpful in maintaining your strength and pushing you a little bit more further to opening your mouth when it feels really hard to open your mouth. And the other thing is that between the times that you do it, and you hold it for like, 5 or 7 seconds, you take the whole thing out and then you put it back in, because just the task of opening your mouth again to put the tongue depressors in gives you another extra stretch.
Thank you. Thank you for that.
Oh, thank you. Yeah.
Do you have any questions from online? We'd like to make sure our online community has some questions at
We
press.
do. Sure, let me take one from online. This was one thing that I think a lot of our patients asked too, which was for Terry and Heather, can you elaborate a little bit on preventing trismus? And, can trismus be prevented for all patients? And a little bit more about that for stopping it from developing.
Okay, I'll take it. First of all, I feel very fortunate to start it. Can you hear me? Is it on? Okay. To get it started and to get it going is always educating your doctors and your team. And I'm fortunate, my surgeon, my ENT surgeon is here. He also has a great team of PAs who are immediately sending them to me right after surgery and right before treatment. So just getting them in the door to see me right after treatment or right after surgery or right before treatment, I'm assessing all of that in my initial visit. So I'm already looking at it. So if somebody comes in right after surgery and they're measuring 38, which is normal, I know radiation's going to be worse, so I'm going to get you started. And in my head, I'm already thinking about getting you to my colleague afterwards. So it's really, I feel like making sure that you're staying ahead is having a good relationship with your doctor, your surgeons, your radiation oncologist, and requesting the referral. Because usually, I would say 99% of the time, that's the number one, but then it's also looking for a cure. So just also advocating for that referral for speech or physical therapy.
Yeah, maintaining the mobility before you lose it is often the best way to prevent it, but.
And I think I also said too, with the caregivers, when you notice just a little bit of a change, I always tell my patient that little bit is a big deal. Just a little bit that you think, oh, it's not that big of a deal, call them. And then I also make sure that patients know 3 fingers. Can you get your 3 fingers in? If it's getting you think it's a little tighter, it is a little tighter. So it's just kind of knowing those little tricks too, that you're just kind of watching and getting ahead of things.
That's really helpful. We'll take one from back there.
Thank you very much for the excellent presentations. And I have 2 questions, one for Heather and Terry. What is your protocol for survivors at 5, 10, and 15, and 20, and 25 years. And Wade, I was really struck by your comment about feeling better, and particularly psychologically, and having that reason to live. Can you expound on that just a little bit about what was your journey that led to that revelation? It's something as a physician I have heard many, many times, and I'm always struck by that, that even though physically you're not swallowing as well, you don't have as much energy, you're dry, psychologically it seems there is a transformation in many people, and I'm always interested in their journey. Thank you.
The psychological piece for survival is absolutely essential, and for me, it really was about my family and needing my family and not wanting to leave my family so early. But I have to say, I didn't always handle the journey well. I was really afraid that maybe I'm not going to make it. I had stage 3. I had some very, very rough days. And I think it's okay to feel like that sometimes. But on the other hand, I had to be mindful of caregivers too. You don't want to dump on your caregivers because they're your first line of defense. So I would sometimes be in very dark places, and then other times, but the psychological piece of wanting to be with my family was far stronger in the end than the dark places. I think the dark places were really at the very beginning. Imagine being in a doctor's office and matter-of-factly telling you, oh, yeah, I see what you have. You have throat cancer. And how do you react to that? It's such a shock. And I think it took me a while to get out of that really dark place. But at some point, there has to be something that you have to fight for, I believe. It could be your work. There's something, unfinished business that you have. It could be, in my case, family. It could be a myriad of options. But the psychological piece for me was just as important as physically recovering. I hope I'm answering your question. So I have to say the psychological piece is tremendous, and a positive attitude, which I did not always have, quite frankly, is essential. I know there's a lot of books written about it, and yes, it took me a while to get there, but I will reiterate that I would say from a psychological standpoint, I am so much happier today than I was 4 years ago. So it is a huge piece.
Did Terry and Heather want to answer on the first question?
I was going to say, I kind of forgot it. I was listening to Wayne. Could you mind repeating it?
5, 10, 15 years, what's your protocol for exercises, and do you still continue to see people, or do you set them on their path?
So I think that varies from facility to facility. What my protocol is during chemo radiation, I am telling you to do them over and over. Do it every day, hit it hard, hit it hard, hit it hard. Then I see people 3 months after radiation and remind them, you need to continue to do the exercises 1 time a day, and then I kind of I remeasure and give them numbers, because numbers are hard. And I do every 3 months for the first year, you have to do your exercises every day. At the 5 and the 10 year, I sign off after 5 years, because I feel like after a year of me telling it, you got it or you don't. But at 5 years, even just having that, or even the year after, I've noticed if patients know what to look for and they have that routine in place, then they'll either see me immediately in 5 years, they know to contact me, or they know to contact my physical therapy colleagues to get back in. So I feel like if you can give patients like a handout, 3 fingers, or if yours is 2 fingers, if it gets tighter than that and you're checking it every day, call me. Call the physical therapist. So I feel like, and even as a physician, if you're noticing it's tighter, immediately in to physical therapy or speech.
Let's take one from here.
Good morning. My name is Gary Negretti, here from Southern California. Coming up on my 15th anniversary, I kind of refer to that as a diagnosis. Squamous cell carcinoma with an unknown primary here in the neck. And Dr. Surkars from UCLA here was the one who did the surgery. Before we talked about, and I said, you know, I want one of those really big neck scars, jagged, so that when I walk around, I'm like, yeah, come on, baby, let's do. Well, when I read the surgical report, he had written that he found a convenient neck crease to put my scar. I'm like, oh, dude, that's not what I wanted. But my primary question, and it's addressed to everyone, and thank you so much for coming up. Again, somebody mentioned that we learned so much by just being around. The first time I got associated with another group from the university down the street, University of Southern California. It was I walked out and I said, these are my people, because they know. They know how to treat it. They know how to talk to you. They know what it feels like. They know, I apologize, have my back to you. And I have my hand on my caregivers. Oh my God. The question, sorry. Being out so far, the 3-finger method, for me in my youth, it was how to whistle. That's what I knew as 3 fingers. The question, and somebody brought it up, what about those of us that are years down the road? Is it too late? I'm going to answer my own question. I'm sure it's not. But what are the things that we can do, and then how do we spread that message? I thought I was done with radiation when they did that, but then they said, no, chemotherapy. Okay, so I did chemo. And then right after that, osteoradionecrosis from the radiation, the gift that keeps on giving. Treatment on that, hyperbaric chamber. So I went from there. But I say this to all of you, this is my new normal. This is our new normal. But there's still more things to learn. How do we get the message out specifically, my question, with trismus? Bam, that's what I've been experiencing. I need help. And I'm asking, because there's more of us behind me, and we need to get them that message. How do we get that message out? What is that message? Thank you all.
How do you get I think this is how you get the message out. You know, it's like, if I think about 7 years, HPV-related cancers, nobody knew about. But now I'm seeing it on TV. Now my dentist who wasn't checking is now checking. So I think it's not just, it's just every time going to meetings like this, talking about it, but then also, I think everybody in this room, when you go to your dentist, when you go to your ENT, I even have patients that tell me, and I was like, I'm doing this talk, and they say, I wish you would have told me in the very beginning, or I wish you would have told me how bad it was, because I sometimes will admit, I just don't want you to quit treatment. So I hold back on the bad news, but sometimes you need to know, like, hey, this is a lifelong thing, these exercises. So I think even for my own growth, teaching people, I've kind of evolved in teaching people those things. I think, you know, in finding where that baseline is, because if people know what to look for and they have the roadmap, or the caregivers have the roadmap, then you're able to prepare. But getting it out, I think it's just going to conferences, actually talking about it. And I think there are, like, new things coming out regarding it. I have colleagues that are at UCSF that are even doing more research on it and getting that out. So I think it's just talking and spreading awareness, I guess, is the big thing. And for me, even going, Brenda Villegas, who will be here later, I remember she initially mentored me because I was like, I don't know what I'm doing. I got to do this. And she told me too, and I will say this for any healthcare provider, to go to the support groups, because I think that was the best thing for me. It was going to the support groups because I learned how to counsel and I learned how to get resources. So not only do I know what to look for, if you go to any dietitian I work with, they're like, Heather, he could only get one finger. He needs to see you right away. So sometimes I get referrals from dietitians and I get referrals from social workers, which wasn't happening before. So I think it's just talking about it and making sure that we all are sharing it every time we get a chance, because that's how I learned.
And at UCLA, my colleague Francis and I, we try to meet with the physicians in different areas, surgeons and radiation oncologists, and to educate them on what we have to offer, so that if they see a patient who needs it, it's more like a commonplace, like, oh, okay, here, go to physical therapy, so that the patients can get to where they need to go. And then the support groups are wonderful, and that's how it gets spread amongst survivors and caregivers.
This is a wonderful discussion. Unfortunately, we're running out of time. I want to make sure we have time for one more online community question, but remember the index cards on each table to please write your question down, and we will get to all of them at another time.
Fantastic. Yeah, I'm mindful of the clock too. Maybe we're in LA and a lot of people have access to these studios, yoga studios, wellness spas, medical spas. Is there a role in red light therapy or any of the newer practices that people are getting offered to for trismus, fibrosis, any of these recoveries?
I defer to Dr. Joel Epstein. I was like, I think, I know that it's out there. I just don't know as much about it because sometimes they get referred and then I never see them. So.
Yeah, maybe some evolving science is there. I think we're about up on time. There's a long list of questions here and in the audience, and I've just been reminded that if we can be a little bit sharper in asking the questions to the panelists in the subsequent sessions, I'll get more people's questions answered in the panels. But let's thank Wade, Heather, and Dr. Tefanian one more time. Thank you, everyone.